First of all, I would like to say thank you to Dr. Frankos and Dr. Dimitriadou, and to all of you as well for having me here today. During this session, I will try to share with you some information from the perspective of a clinical endocrinologist regarding the diagnosis and treatment of hyperthyroidism. Hyperthyroidism is 5 times more common in women than in men. Its prevalence is approximately 1.3%, increasing up to 4 to 5% in older women. And as in almost every other disease, it is more common in smokers. Graves' disease, which overall is the most common cause of hyperthyroidism, is seen more often in younger women, while toxic nodular goiter is more common in older women. Now, the causes are divided according to the uptake of radioiodine, those with a normal or high uptake, and those with a near or absent radioiodine uptake. Graves' disease, hashitoxicosis, and toxic adenoma and toxic multinodular goiter are the most common cause in the first category, and thyroiditis, exogenous and ectopic hyperthyroidism in the second category. Exogenous hyperthyroidism is actually not very uncommon, especially nowadays. There are many herbal supplements over the internet that they contain thyroxine, and many women desperate to lose weight, they use them in order to lose weight. So if you have a patient that has the symptoms of hyperthyroidism, the blood tests agree with them, and they have a small or non-palpable thyroid, and if they're trying to lose weight, suspect exogenous hyperthyroidism. I am pretty sure that you're all familiar with the clinical manifestations of hyperthyroidism. We may have anxiety, emotional lability, weakness, tremor, palpitations, increased intolerance, and increased perspiration. Weight loss is very, very common, despite an increased appetite or normal appetite. However, especially in younger women, we may not have weight loss, but paradoxically weight gain, especially at the beginning of the course of the disease. Milder hyperthyroidism has symptoms that are referable to one or only a few organ systems. Other conditions that should make us suspect hyperthyroidism are osteoporosis, especially in a younger patient that doesn't have any other risk factors for osteoporosis, hypercalcemia, heart failure, premature atrial contractions, shortness of breath, and deterioration in glycemic control in an already known diabetic patient. Thyroxine has a dual effect on diabetes. On one hand, it stimulates the secretion of insulin from the pancreas, and on the other hand, it increases the resistance in the peripheral resistance to the action of insulin. It seems that the second effect prevails. For that reason, we overall have an elevation and deterioration in the glycemic control. In older patients, the symptoms are usually cardiopulmonary, and keep in mind the term apathetic thyrotoxicosis, in which the patients, while they are severely hyperthyroid, their only symptoms are weakness and asthenia. The skin is warm, may rarely be erythematous, there is sweating, there is onycholysis, softening of the nails, hyperpigmentation. Increased pigmentation in hyperthyroidism occurs because you have increased levels of cortisol-binding globulin, leading to lower levels of free cortisol, and through the feedback mechanism, you have higher levels of ACTH, which may cause increased pigmentation in the skin. Pruritus and hives are more common in Graves' hyperthyroidism. We may have vitiligo, alopecia, and thinning of the hair. Pretibial myxedema occurs only in Graves' disease. It is characterized by raised, hyperpigmented, violaceous, orange peel texture papules. Stare and lid lack occur in all patients with hyperthyroidism. However, only patients with Graves' disease develop thyroid ophthalmopathy. You will see in the picture the different stages of thyroid ophthalmopathy. There is inflammation of the extraocular muscles and orbital fat connective tissue, exophthalmos, impairment of eye muscle function, and periorbital and conjunctival edema. In severe cases, you may have diplopia, corneal ulceration, optic neuropathy, blindness. The pathomechanism of Graves' ophthalmopathy is very complex, and we still do not have a completely clear picture of it. It appears that elevated levels of TSI, thyroid-stimulating immunoglobulin, and certain cytokines released from T cells, such as tumor necrosis factor, they play a crucial role by increasing hydrolytic glycosaminoglycans, which in turn causes an increase in the osmotic pressure, leading to swelling of the extraocular muscles and the retroorbital tissues. Probably the only factor that we can modify that can favorably affect the course of the disease is to strongly advise our patients to stop smoking, because smoking has been associated with the development of more severe thyroid ophthalmopathy compared to people that they don't smoke. Hyperthyroid patients, most of the times they have tachycardia, white pulse pressure, systolic hypertension, and congestive heart failure sometimes. Atrial fibrillation occurs in 10 to 20% of patients with hyperthyroidism, and as expected is more common in older patients. From these patients, approximately 60% will convert spontaneously to normal sinus rhythm within 4 months after achievement of euthyroidism. Controversy exists as to whether these patients with atrial fibrillation and hyperthyroidism should be anticoagulated or not, because 10 to 40% of these patients were found to have an arterial embolus, and because in hyperthyroidism we have atrial fibrillation, which is a risk factor for thrombus formation, most authorities, they recommend that these patients should be put on anticoagulation. Patients may have dyspnea and dyspnea on exertion, respiratory muscle weakness, tracheal obstruction from a large goiter. Weight loss may be present, increased gut motility, hyperdification, and malabsorption. We have to be careful that in hyperthyroidism, we don't have diarrhea, but we rather have hyperdification due to increased frequency of bowel movements. Importantly is that we may have abnormalities in liver function tests, and this is important because before starting treatment with ionamides, as we will see later on, we need to get baseline liver function tests. From the genitourinary system, we may have urinary frequency and nocturia, probably due to elevated serum calcium levels that leads to hypercalciuria and polyuria. In women, we may have oligomenorrhea and anovulatory infertility, and in severe cases, we may have complete amenorrhea. In men, because of increased aromatization of androgens to estrogens in the periphery due to the elevated levels of thyroid hormone, we may have gynecomastia, reduced libido, and erectile dysfunction. It is interesting that in men we have reduced libido because in women with hyperthyroidism, we find increased sexual drive. Now, osteoporosis and osteopenia are one of the most serious long-term complications of hyperthyroidism. Thyroid hormone stimulates bone resorption. We have high elevated serum alkaline phosphatase and osteocalcin concentrations. Calcium levels are increased, inhibiting PTH secretion and the conversion of calcidiol to calcitriol. All these lead to impaired calcium absorption and increased urinary calcium excretion. We have to make sure that all patients with hyperthyroidism, they receive adequate calcium and vitamin D supplementations. Patients are very restless and very agitated, and they speak fast. There might be lid retraction and lid lack. The skin is warm and moist. There might be thin hair. Tachycardia is common. And the pulse is irregular in patients with atrial fibrillation. There might be a tremor, proximal muscle weakness, and increased deep tendon reflexes. The eye findings were described in the previous slides. The thyroid size can be variable. It depends on the cause of the hyperthyroidism. There may be thyroid enlargement from minimal to massive in patients with Graves' disease or toxic multinodular goiter. Elderly patients, on the other hand, may have Graves' disease with a small, non-palpable thyroid gland. Patients with thyroiditis may have no minimal or modest thyroid enlargement. Again, the absence of any thyroid enlargement in the setting of hyperthyroidism should raise suspicion for exogenous thyroxine ingestion. Finally, the thyroid is exclusively painful and tender in subacute painful thyroiditis. Sometimes the thyroid is so painful to touch that the patients won't let you examine it. You're familiar with thyroid function test. TSH 54 and 53 will give us a diagnosis in the patients with symptoms. In some institutions, they check only TSH and they proceed to 54 and T3 measurements only if TSH is abnormal. Overt hyperthyroidism, the diagnosis is straightforward with symptoms and very low TSH and elevated 54 and T3. T3 toxicosis, in which you have disproportionately elevated levels of T3, is found in Graves' disease or nodular goiter. T4 toxicosis is found in patients with hyperthyroidism and concomitant non-thyroidal illness. Amiodarone will also cause T4 toxicosis because among the other effects amiodarone has on the thyroid gland, it also inhibits the conversion of T4 to T3. Subclinical hyperthyroidism, we have low serum TSH concentrations with normal free T4 and T3. Subclinical hyperthyroidism should be treated, especially in elderly patients, because it increases the risk of atrial fibrillation 3 times. Now, TSH-induced hyperthyroidism is very, very rare. It can be due to the presence of a TSH-secreting pituitary adenoma. Personally, I've never seen one, or due to the presence of partial thyroid hormone resistance. Suspect thyroid hormone resistance in a patient who has elevated TSH, symptoms of hyperthyroidism. If you check free T4 and T3, they will also be elevated. Other non-specific laboratory findings are abnormalities in lipid profile, a normochromic normocytic anemia, and as mentioned earlier, elevated serum ALP and osteocalcin concentrations, as well as elevated liver enzymes. When the diagnosis is not straightforward, we may proceed with further testing. Thyrotropin receptor antibodies, otherwise known as thyroid-stimulating immunoglobulins, have a sensitivity and specificity of 97 and 99% for diagnosing Graves' disease. Where it is easily available and accessible, the radioactive iodine uptake is a very useful tool. In cases that we don't have easy accessibility, or when it is contraindicated, such as in pregnancy or breastfeeding, measurement of thyroidal blood flow on ultrasound can also be helpful. I am pretty sure that you're familiar with this list. On the right side, we have the causes of hyperthyroidism with increased or normal radioactive iodine uptake, and on the left side, those with lower upset radioiodine uptake. Graves' disease, hot nodule toxic adenoma, and toxic multinodular goiter are the most common causes with high uptake, and thyroiditis are the most common causes with low uptake. If we are in doubt and are looking for help in an ultrasound, if we get pictures like this, we are we should be happy, because on the right side you see brisk increased vascularity, diffuse increased vascularity in patients with the Graves' disease, and on the left-hand side you see the vascularity increased in a toxic adenoma. In real life, however, things are not always black and white. Many times you get patients that are almost sure that they have Graves' disease, and when you do the ultrasound, we find that the blood flow is only minimally elevated, or sometimes it even resembles thyroiditis. In any case, ultrasound can be very helpful. All patients with Graves' disease should receive adequate beta blockage in order to minimize the symptoms due to increased sympathetic activity. Now, regarding hyperthyroidism itself, we have 3 different treatment modalities: thionamides, radioiodine, and surgery. Thionamides, they give a chance of permanent remission and may avoid permanent hypothyroidism. They are also not expensive medications. On the other hand, as we will see a little bit later, they also have some potential side effects, and they require frequent monitoring, which many times the patients don't like. Radioactive is a safe choice. It brings most of the times permanent resolution of hyperthyroidism. It leads almost always to permanent hypothyroidism, and radiation precautions can be inconvenient when you're treating a caregiver, for example, or in a family that has small kids. Surgery gives an immediate and permanent resolution of hyperthyroidism. Again, it causes permanent hypothyroidism. There is the risk of hypoparathyroidism requiring high doses of calcium lifelong, which is not a very pleasant thing to happen, recurrent laryngeal nerve injury, and it is expensive. There are 3 thionamides available: methimazole, carpimazole, and PTU. Carpimazole is converted to methimazole in the bloodstream, and its potency is approximately 60% that of methimazole. So if a patient is taking 20 milligrams of carpimazole, the equivalent dose of methimazole is around 14 milligrams. Always obtain baseline blood test, including a complete blood count and liver profile before starting treatment. Generally, methimazole is preferred over PTU. It brings a more rapid achievement of euthyroidism. It can be given once daily, leading to better compliance from the patient's side. It has little or no effect on subsequent success of radioactive therapy, and overall is considered to be less toxic. Side effects of thionamides are pretty common. Up to 13% of patients may have pruritus or rash or other allergic reactions, which can usually be managed with concomitant administration of antihistamines. Other side effects that are common are arthralgias, arthritis, and fever. Methimazole is potentially teratogenic. It has been associated with aplasia cutis and other congenital malformations. Agranulocytosis is a serious side effect. It occurs in 0.1 to 0.5% of the patients, usually during the first 2 months. We have to warn the patients regarding the signs of possible low white cell count, such as sore throat, development of fever, or any other site of infections. ANCA-positive vasculitis, it rarely poses a problem because it is usually asymptomatic and occurs almost exclusively with PTU. What is important, though, is the hepatotoxicity that may happen with PTU. 1 out of 10,000 of patients taking PTU may develop elevated liver enzymes and liver failure. It usually starts within 90 days of starting the medication, and it is not dose-related. It is controversial whether we should monitor liver enzymes routinely. The authorities don't recommend to do so, but if you do, it's not a mistake. You should always warn the patients for signs of possible liver failure, such as jaundice, nausea and vomiting, abdominal pain, and darkening of the urine. Radioactive can be given in Graves' disease, in toxic adenoma, and toxic multinodular goiter. It is preferred by more specialists in the United States. 60% of specialists there prefer to use radioactive compared to only 13% in the European Union. I don't know why this is happening. I don't know what's the reason behind it. From my personal experience here in Cyprus, I believe that the patients get very, very skeptical when they listen to the term radioactive. And I think it's also our job to make them feel more comfortable with this treatment. In addition, we have too many surgeons. I believe that we have too many surgeons here, that they are pretty successful in convincing the patients to go for surgery instead of doing any other treatment modalities. And I don't know if Savas and Rena will agree, but we still need to work on that a little bit more. Pregnancy and breastfeeding are absolute contraindications. About the dose, you will have a whole lecture coming up. Now, radioiodine can be given immediately after the diagnosis is made. In certain occasions, however, we have to pre-treat the patients with thionamides. This should be done in elderly patients with symptoms or cardiovascular disease or other patients with thyrotoxicosis that they cannot tolerate the symptoms. Usually, it is enough to stop the treatment 3 days before and restart it 3 days after radioiodine. After treatment, free T4 should be measured 6 to 8 weeks after radioiodine is given, and then at 4 to 8 week intervals thereafter. TSH is not useful in the post-treatment period because it will remain low for some weeks. Now, we all know the relation of radioiodine and ophthalmopathy. It is still controversial as to whether thyroid ophthalmopathy presents a contraindication to treatment with radioactive iodine or not. Generally, most specialists will avoid radioiodine in patients with moderate to severe ophthalmopathy. If we choose to use radioiodine in patients that they have severe ophthalmopathy or those with mild ophthalmopathy, we may prevent worsening by the concurrent administration of glucocorticoids. Now, radioiodine, cancer, and overall mortality. Now, analysis of data through 1990, representing a mean follow-up of 21 years, show no increase in overall cancer mortality. On prolonged follow-up, it was found a small increase in thyroid cancer risk that was more pronounced in those patients who received radioiodine for toxic nodular goiter. It is believed that it is not due to the radioiodine this increased the risk in cancer mortality, but it is because of the presence of the nodular goiter itself, which increases the risk for thyroid cancer. Similarly, in overall mortality, there was a slight but significant increase in later mortality. But again, it is related to hyperthyroidism itself and not to the use of radioiodine. So we have to ensure our patients that radioiodine is a safe mode of treatment. Now, surgery. Surgery can be done in patients with Graves' disease and those with toxic adenoma and toxic multinodular goiter. The way you practice medicine today, we present the patients the data, we give the pros and cons of each different treatment, and we help them to choose what is the best treatment for them. So many of them, they prefer to do surgery instead of any other treatment. Other indications for surgery are very large goiters, airway obstruction or severe dysphagia, the presence of a nodule that might be cancer, moderate to severe case of ophthalmopathy, pregnant women who cannot take thionamides, and persistent hyperthyroidism despite the use of radioiodine or thionamides. You know the contraindications to surgery. Now, in the past, the surgery of choice was subtotal thyroidectomy in an effort to preserve some thyroid tissue and avoid permanent hypothyroidism. However, due to high recurrences of hyperthyroidism, the surgery of choice today is total or near total thyroidectomy. The patients should be made euthyroid before surgery. No surgeon likes to operate on a thyroid gland that is soaking in blood, so we have to pretreat them with thionamides. We have to use beta blockers, and we may use inorganic iodine, such as supersaturated potassium iodine, which decreases thyroid secretion and decreases as well thyroid vascularity. Complications are known: wound infection, keloid formation, which can be bothersome, especially if we operate on a young woman, transient and permanent hypoparathyroidism, and recurrent superior laryngeal nerve injury. I'm going to finish with hyperthyroidism during pregnancy. It's a very important issue. Hyperthyroidism complicates 0.1 to 0.4% of all pregnancies. Complications are spontaneous abortion, premature labor, low birth weight, stillbirth, preeclampsia, and heart failure. During early pregnancy, we have high serum HCG concentrations. HCG structurally resembles TSH, so in a way it tricks the thyroid gland to produce more thyroxine. In patients with hyperemesis gravitarum or multiple pregnancy, the levels are even higher. We may have transient subclinical or rarely overt hyperthyroidism. You have to keep in mind that in pregnancy, in the first trimester, the lower limit of the reference range for TSH is lower than in non-pregnant women. So you have to keep this in mind when we evaluate thyroid function test in pregnant women. HCG may cause gestational transient thyrotoxicosis, usually at the 10 to 12 week, and subclinical or mild overt hyperthyroidism. Hyperemesis gravitarum, which happens in 0.1 to 0.2% of pregnancies, is associated with nausea and vomiting and high levels of HCG and estradiol levels. In both cases, no treatment is needed. The challenge that we are facing as endocrinologists is to differentiate between HCG mediated hyperthyroidism and Graves' disease. Usually, if it is due to HCG, the thyroid function test will normalize, will start going low as the pregnancy progresses and the HCG levels fall. Now, those with mild disease or are asymptomatic, they can be followed and monitored without treatment. The treatment of choice in pregnancy are thionamides. Until a few years ago, the drug of choice was PTU, and we were using PTU throughout the whole pregnancy. Due to raising concerns regarding hepatotoxicity, this has changed recently and the guidelines have changed. On one hand, we have methimazole, which is a medication that is potentially teratogenic, and on the other hand, you have PTU, which is potentially hepatotoxic. Methimazole can also elevate liver enzymes, but the mechanism is cholestatic. So now it is recommended that we use methimazole, we use PTU during the first trimester, and to switch to methimazole or carfilzomib after the first trimester is over. We have to be careful during the switching period not to make the patients hypothyroid, as methimazole is more potent than PTU. A rough estimation when we are doing the transformation from PTU to methimazole is that 1 milligram of methimazole corresponds to 30 milligrams of PTU. I think I will stop here. There are many other aspects regarding hyperthyroidism, but unfortunately, we are limited by time. We can have a whole seminar regarding hyperthyroidism. I would like to thank you for your patience and your attention, and I hope that you will enjoy your stay here in Limassol. Thank you very much.